A patient on apixaban or any other NOAC presents with an acute ischemic stroke and he is within the thrombolysis window. Most of the people freeze because anticoagulate means no TPA. But let's see what's the trap. Anticoagulation is often not an absolute contraindication. It depends on the drug, timing and the coagulation status of the patient. Thrombolysis with alteplase works by converting plasminogen to plasmin and then lysing fibrin clots. But in anticoagulated patient, hemostatic balance is already impaired. Warfarin reduces vitamin K dependent clotting factors like 2, 7, 9, 10. NOACs directly inhibit factor 10A or thrombin. Adding thrombolysis on top of this can exponentially increase the intracranial hemorrhagic risk. So the decision hinges on the residual anticoagulant activity at the time of presentation with stroke, not just the history of drug intake. So if you look at the guidelines, AHA, ASA, and multiple registry data provide clear thresholds. Warfarin, if the INR is more than 1.7, thrombolysis is contraindicated. Less or equal to 1.7, go ahead with the thrombolysis. In DOACs, apixaban, rivaroxaban, and dabigatran, if taken within last 48 hours, generally avoid thrombolysis. If it is more than 48 hours with normal renal function, you may consider thrombolysis. Now, the important trial like RELY and subsequent stroke registries highlight the variability of drug clearance, especially in people with renal dysfunction. And here the clinical pearl happens. Routine PT-INR is unreliable for NOACs. And a normal INR does not mean safe for thrombolysis in NOAC patients. You need to know anti-10A levels for 10A inhibitors and thrombin time for dabigatran. But these are rarely available in real time, and by the time you get the result, the patient will be out of the window period. So when in doubt, use time and renal function as your surrogate markers. Ask two questions in these patients. When was the last NOAC dose taken? And what is the creatinine clearance? For dabigatran, you can use idarucizumab for the rapid reversal before thrombolysis, and technically factor 10A inhibitors can be reversed by andexanet, but not routinely recommended, and no evidence among these reversal agents are available. So in large vessel, you can directly go ahead with mechanical thrombectomy independent of the anticoagulant status. So in an anticoagulant patient, don't ask, can I thrombolyze? Ask, is there residual activity of anticoagulant right now in this patient? If no, you can go ahead to do thrombolysis.